I have the knowledge and I can give you that knowledge, but you have to be very proactive also so that we partner together. It's a partnering. I'm Dr. Elenita Usher. I'm from Belize, which is a country in Central America. That's where I grew up. I went to college there and then went to Guatemala, and I studied medicine in Guatemala City. After finishing medicine there, I went back to Belize and worked as a general practitioner for a few years before deciding that I needed to further my career, and I came to the United States. I had to do the United States medical exam, the USMLE, to get licensed here in the United States. So I spent a few years doing my USMLEs so that I can get certified to be able to practice medicine in the US. After that, I went into the residency program at Texas Tech University Health Science Center in Odessa, the Permian Basin. I did family medicine there. And after family medicine, or during the rotation, is when I became inspired to do geriatrics. I had a great mentor who was a geriatrician, and he showed me everything that was possible in geriatrics, and I got motivated. He encouraged me to do the fellowship program there, and I did the one-year fellowship program, and that's how I did the specialty in geriatrics. Looking back, I think I was interested in medicine since I was a child. I remember playing my dolls and being the doctor all the time, checking the temperature, giving injections, saying they're sick, and I was treating them. I didn't have any influence at the time, so I don't know where it came from. I guess it was just natural, or maybe I did a doctor's visit. I don't remember, but that was as far as I can remember. And when I finished college, I knew that's what I really wanted, so I did everything in the sciences while I was in high school and college. And then my parents didn't believe that girls should study medicine, so they kind of discouraged me, but I was set, and I decided I'm going to go that pathway, and I never wavered. I am in the same pathway, and I'm enjoying it the fullest. So through residency, I had a mentor, Dr. Chow Lei. He was a geriatrician at our program. He was passionate about geriatrics. I never thought I would do geriatrics. Actually, I didn't know much about geriatrics until I went into that program. And I would see the way he talked to patients, his bedside manner, his insight into what aging is, and the changes that you can make in patient care when you look at the patient holistically, the social aspect, the physical, the mental, and then combining that and getting a good thorough history, which in medicine we should do, get a good thorough history, and then coming up with a plan of care. And I could see the change and improvement in health when you look at that patient individualized and then come to an assessment and then go with the patient care that's specific for that patient. You see changes and improvement is in the quality of everyday life that you see. So that patient can go from being bedridden to becoming independent, or at least meeting what that patient goal is, because everyone has their own goal. The older we get, so when we're young, it's like we have all these guidelines that medicine gives us. You treat diabetes this way, you treat hypertension this way, you treat congestive heart failure with these guidelines. When you become in the older age group, the older you become, it becomes more individualized. Yes, we try to follow some guidelines, but now how will that affect you individually as a patient? So that's where we stand back and say, okay, giving you this medicine, What is the side effect? How will that impact your everyday life? Will it cause dizziness? Will it cause sleepiness? And then that's where we say that is the individualized medicine that we're seeking in geriatrics. And that is what made a big impact in making the decision that this is where I really wanted geriatrics. Being bilingual, being able to speak English and Spanish, I can relate to the general population, especially in San Antonio. Is a large Hispanic community. It has a lot of the underserved Hispanic community also, where it's difficult to access a physician who can speak their language and understand not only the language, but sometimes you need to understand the culture. If you understand a little bit of the culture, then you can relate more closely to why maybe a care plan is not working for them. And so you have to adjust and discuss and educate. A lot of it has to be education, especially in their language, so they can understand. And at the literacy level that they are, because if you don't speak at their literacy level, it's more difficult to bring across why you're giving such a treatment and why that treatment is of benefit to their health, so that they can improve their health and also be proactive. Because you need to have a patient to be proactive in their care so that you get better results. And I think speaking Spanish and relating to the Spanish-speaking community, that is a big impact, especially here in San Antonio, where we have diabetes and chronic kidney disease. But if they're not understanding why we give certain medicines for their conditions, then we can't get across to them and improve their health. So during the course of my clinical experience, I think diabetes is one of the #1 medical conditions that we see in our clinics, especially in San Antonio, with the obesity rate and the Hispanic community especially, it's very high. Having to treat patients with diabetes requires a lot of time, effort, education especially, education on lifestyle changes, especially when it comes to diet, medication. There's so many medications that are out there that we have to be tapering, adjusting, and also instructing the patient how they themselves can monitor their glucose control and adjust their diet according to what that glucose control is. Because if you're able to test yourself and know what a reading signifies, then you know that you can adjust your diet for that day to either lowering your caloric intake, increasing your caloric intake, so that you can have better control. And the entire goal during the clinic visit is to stress that this is important so that we prevent complications. The chronic kidney disease ending into end-stage renal disease, which is high here in San Antonio. Complications of diabetes leading to neuropathy, where then, if it's not controlled, ends up with amputations due to peripheral vascular disease from uncontrolled diabetes for years after years of not having a good management. So stressing the importance, I think education is #1. If we educate and we let them understand, then the rest falls into place. In my subspecialty as a geriatrician, I see myself as a physician who looks at the patient holistically. I look at the patient's goal. On the first visit, we do a geriatric assessment. So this geriatric assessment is to give me a picture of who the person is, not just physically, but mentally, socially. And then we review your medical conditions and your medications, and then discuss what your goal is. So why are you here to see me? A lot of patients have their primary care physicians and they're happy with their primary care physicians. However, they are complicated, or they have been with their primary care physician and decide this is no longer what I need. I have a different goal and I'm not seeing that goal with my primary care physician. So on that first visit, that's when we do an assessment and decide what we do. A case that comes to mind that I can give an example of what a geriatrician does is a female patient of mine that came to my clinic, 80-odd years old, and she lived independently at one of the retirement communities, and she said, "Dr. Usher, I have been going to the ER almost every month. I'm tired of visiting the ER every month. And now it's coming to nearly every week. I collapse, I'm dizzy, I go dehydrated, I go because I have chest pain, I go because I'm falling at home. I'm tired of that. I need your help." So we reviewed the patient's medical conditions, reviewed her medication, discussed her goals. Her goals was decrease the ER visits. That was her goal, decrease the ER visits. She was independent, living home alone, very smart lady, and had a few medications only. One was cardiac medications and the other was asthma medications. So I did my assessment, figured out where she is in her lifestyle, her social, medical, and did some blood work, the general blood work to check kidney, liver, thyroid, and told her I was going to get some information from her cardiologist to see what was going on. She had a cardiac arrhythmia, and according to her, that was the cause of why she was always in the ER. She had cardiac arrhythmias. On the follow-up assessment, I had already received the cardiologist's reports, and so I discussed with her. I said, "You know what? So when was your last asthma attack?" She said, "I haven't had one for a year." "Do you remember having in the last 2 years?" "No." "So how long have you been on this long-acting asthma medicine?" She said, "I don't know, many years." "No one took it off?" She said, "No." "So why do you take it?" "Because my doctor gave it to me." So I said, "Okay, you haven't had an exacerbation, so you need to take it off. Take it off. We're going to treat you only with rescue medicine. If you have shortness of breath, and I told her the symptoms, you can use your rescue medicine, but don't use your long-acting asthma medicine." That was the start. The other one was 2 anticoagulants, Plavix and aspirin. I said, "Okay, we can keep that," and we discuss side effects. We look at the other medications for the heart. We discuss side effects, and we said on a follow-up visit, we'll decide what we're going to do. Well, the follow-up visit wasn't too long after. She had fallen and had a large hematoma on her leg, big bruise, and we had to stop Plavix and aspirin. She was bleeding, huge hematoma from a simple fall at home. So we stopped it. On the follow-up visit, once the hematoma resolved, we said, "Okay, I don't think you need both." She had already said, "I don't want to go anymore to the cardiologist. I don't want to go anymore to the ERs. I'm fine." So we discussed palliative care. She didn't meet the criteria yet, but we said, if you have these goals, we're going to do it this way. We stopped the Plavix, decreased the aspirin, monitored her, and this lady has not had an asthma attack in 2 years. She hasn't gone to the ER since she came with me. She follows at the clinic, independent still in her retirement home, walking every day, going to the library, volunteering, and I think that's a good outcome. Yes, medicine changes so quickly, and the evolution is so fast-paced. So the way I find that I'm able to keep up with the most updated information is attending conferences. So I'm a member of the American Geriatrics Society, American Academy of Family Medicine, and I every year find time to attend those sessions, the conferences, and keep up to date with the information. Apart from that, I get my regular journals that I usually find time to read on the topics that I see most in my patient's care. If there's a new diagnosis that a patient has that I'm not familiar with, definitely I look it up. And I use the internet a lot. So a lot of the time, while I have free breaks or while lunch, that is how I keep up with what is trending. And then if it's in something that really is important to me and my patient care, then I go farther and read the articles. I think that is what has helped me maintain up to date with the care of the patient. I find my profession very rewarding. I enjoy talking to my patients. I enjoy knowing who the patient is. So, where are you from? What have you done? Why are you in here? Like, what is your goal right now from where you were before? And just learning the family. Like, okay, what's your family like? Because then I can get a better perspective of who you are and where your goals might be. And then I think I can serve you better that way. So it's rewarding for me having a patient in my clinic and getting to know the social aspect. Apart from the physical, I think in geriatrics you have the ability to sit and make conversation. Spend a little extra time to know who that patient is, so that then you can make a better plan of care for that patient. My perception of the duty that the physician has to their patient is to be a coach or a teacher and a guide to improve the health of the patient. So we're not there to say, do this, 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 and not explain the reason why. You come to me with a problem, you give me your confidence, you share very personal and intimate information. So we guide that with a lot of respect. And if you put that trust and faith in me, then I think that my duty to you is to do the best that I can to answer the questions that you have with regards to your health, be it physical, mental, social. Try to assist you in finding the best possible answer, because that's what the patient wants, an answer. How will I get better? How will treating my diabetes make me have a better life? So I'm there as a coach and as a guide. I have the knowledge and I can give you that knowledge, but you have to be very proactive also, so that we partner together. It's a partnering relationship that we have. It's not one-sided, me telling you what to do, but it's me assisting you and educating you in what you should be doing to help improve your health, your life, the quality of life especially, because that's what matters in the end. What is your quality of life? Because you could live years bedridden in a wheelchair, or you can live years in good quality, being independent, being healthy, having lifestyle where you're eating healthy and exercising every day, and you're happy with where you are at that moment in your life.